Good afternoon and welcome everyone. While you're waiting, a couple more minutes, take our pre-session survey, which is required to earn a certificate of training for today's session and a continuing education credit. This survey will close shortly into the webinar. So I want to welcome everyone today to today's session, implementation of Enhanced Barrier Precautions for Long-Term Care Facilities, on behalf of Project Firstline Rhode Island and the Center for Acute Infectious Disease Epidemiology here at the Rhode Island Department of Health in partnership with the CDC. Thank you everyone for joining us today. Before we begin, again, I'd like to direct your attention to the chat and introduce Abby Anderson, who is our Project Firstline Rhode Island project assistant. The Project Firstline Rhode Island team is here as well behind the scenes in support of this webinar. And Abby will be posting information for you throughout the webinar via chat. And as a reminder, this session is being recorded. Now, if you'd like to take a minute and introduce yourselves in the chat, tell us your name and where you're coming in from. I'm so glad to see everyone. I'm very excited to be with you today. If you're returning, welcome back. And if it's your first time listening in, welcome. Some reminders. We do have a lot of material to cover today. I know you all have many questions surrounding enhanced barrier precautions, and hopefully the webinar will address most of them. We'll have a brief question and answer session immediately following the webinar, but if we're not able to address the questions live, please leave your email so we can address them after the webinar. And everyone is muted at this time. At the bottom of your screen, you'll see the Q&A box, and please use the Q&A box for all of your questions. We will have a brief session at the end, like I said, and please leave your email. If we cannot respond to your questions live, we will send you the answers via email. And the chat box is available to connect with our behind-the-scenes team members, and if you'd like to be added to our subscriber list, you can add your email there as well. And my name is Stephanie Doyle. I'll be your host and presenter today. I'm an infection prevention training liaison for Project Firstline Rhode Island and a community public health nurse here at the Center for Acute Infectious Disease Epidemiology at the Rhode Island Department of Health. I've been practicing healthcare professionally over 20 years and a nurse for 17 of those years. I've worked in many different roles and have a range of different nursing experience, which has led me to my practice in public health and education. I'm joined today by Dr. Alexis Kearney. Dr. Kearney, welcome, and thank you for being here today.
Hi, everyone. Thanks for being here.
So today we're here to talk to you about multidrug-resistant organisms and ways to prevent the spread of infection caused by these organisms with the use of enhanced barrier precautions. As healthcare professionals, it is our duty to maintain high standards of care to protect the populations we serve who are most vulnerable during their healthcare experiences. Infection prevention and control is important to stay at the forefront of the care we provide. It is vital to keep infection prevention and control a priority to keep our patients, ourselves, and our colleagues safe. So welcome again, and let's begin. I'd like to thank our partners within the Division of Emergency Preparedness and Infectious Disease here at the Center for Acute Infectious Disease Epidemiology, the Healthcare Associated Infections team, and the Center for COVID Epidemiology, COVID Prevention Field Team, and the Long-Term Care Facility Group. And another reminder, this Nursing Continuing Professional Development activity is approved for 1 contact hour credit by Northeast Multi-State Division Education Unit, an accredited approver by the American Nurses Credentialing Center's Commission on Accreditation. In order to receive your CNE credit, the following steps must be completed. So if you haven't done so, please complete the pre-session survey, and Abby has been adding the link to the chat, and the survey will close briefly, so make sure you get that completed. The second step is to attend this live webinar. And you must complete the post-session survey. The post-session survey will be emailed to you tomorrow. These steps are required for a certificate of training. If you would like a continuing education credit, you must complete the post-session quiz. A link to this quiz will also be emailed out to you tomorrow. And for our other healthcare colleagues who are opting for certificates of training, steps 1 to 3 are required, while 4 is optional. All right, so our agenda for today, we've done our welcome and our introductions. We will review our learning objectives. We're going to define multidrug-resistant organisms and discuss the healthcare implication of multidrug-resistant organisms, or MDROs, in long-term care facilities. Then we'll dive into infection control and prevention with a focus on enhanced barrier precautions. We'll have some time to reflect and go over some key takeaways. We'll have some announcements and again a brief question and answer session at the end. And then we'll ask for some feedback, an end of session feedback poll. So at the end of today's session, you will be able to define multidrug-resistant organisms, explain the impact and burden on long-term care facilities, understand how multidrug-resistant organisms spread and lead to outbreak, understand the need to implement Enhanced Barrier Precautions, or EBP, and learn some tips and tricks on how to be successful with implementing EBP. All right, so what are multi-drug-resistant organisms? MDROs are microorganisms, predominantly bacteria, also fungi, that have become resistant to one or more classes of antimicrobial or antifungal agents. Some examples of MDROs targeted by CDC include pan-resistant organisms, carbapenemase-producing, carbapenem-resistant Enterobacterialis, carbapenemase-producing, carbapenem-resistant Pseudomonas, carbapenemase-producing, carbapenem-resistant Acinetobacter baumannii, and Candida auris. Additional epidemiologically important MDROs may include, but are not limited to, methicillin-resistant Staphylococcus aureus or MRSA, extended spectrum beta-lactamase-producing Enterobacterialis or ESBL, and vancomycin-resistant Enterococci or VRE, just to name a few. Although C. diff is not often resistant to antimicrobials, it is sometimes grouped into this category due to its potential significant impact in long-term care facilities. Some of these organisms are considered an urgent public health threat, as published in the CDC's 2019 Antibiotic Resistant Threats Report. We're going to look at a few of those urgent threats in a little more detail now, and talk about what you need to know about these organisms. So the first I'm going to highlight is Candida auris, or C. auris, first identified in 2009, has quickly become a cause of severe infections around the world. It is often multi-drug resistant, with some strains resistant to all 3 available classes of antifungals. It can cause outbreaks in healthcare facilities, and some common healthcare disinfectants are less effective at eliminating it. It can be carried on patients' skin without causing infection, allowing silent spread to others. Next we have carbapenem-resistant Enterobacterialis, or Enterobacteriaceae, or CRE. Back in 2020, a name change was adopted to use Enterobacterialis as the name of a new scientific order. Enterobacteriaceae are now a family within the Enterobacterialis order. So you might see those interchanged. CRE affect patients who require devices such as catheters or have a history of MDROs, patients taking long courses of some antibiotics, approximately 30% can carry mobile genetic elements that are easily shared between bacteria. These elements or mechanisms can produce enzymes, which makes carbapenem antibiotics ineffective. Carbapenemase-producing CRE make enzymes called carbapenemases that inactivate carbapenems and other beta-lactam antibiotics, including penicillins and cephalosporins. The presence of a carbapenemase is usually sufficient to cause carbapenem resistance. Many carbapenemase genes are on mobile genetic elements that can be transmitted from one bacterium to another, thereby spreading resistance. Enzymes can rapidly spread resistance that destroy these important drugs. And lastly, the carbapenem-resistant Acinetobacter, most commonly see as Acinetobacter baumannii, or abbreviated as CRAB, and can cause infections in the blood, urinary tract, and lungs, or in wounds and other parts of the body. It can also colonize or live in patients without causing infections or symptoms, especially in respiratory secretions or open wounds. These can also carry mobile genetic elements that are easily shared between bacteria, which makes most antibiotics ineffective and rapidly spreads resistance that destroys important drugs. Some Acinetobacter species are resistant to nearly all antibiotics, and few new drugs are in development. So how do these bacteria and fungi fight back against the antibiotics used to kill them? Antibiotics fight germs, but germs fight back and find new ways to survive. Their defense strategies are called resistance mechanisms. Only germs, not people, become resistant to antibiotics. To survive, germs can develop defense strategies against antibiotics and antifungals called resistance mechanisms. Some examples of how this occurs are germs can change cell function to resist antibiotics, change or destroy the antibiotics with enzymes, proteins that break down the drugs, restrict access by changing entryways or limiting the number of entryways, change the antibiotic's target so the drug can no longer fit and do its job, and get rid of antibiotics using pumps. DNA tells the germ how to make specific proteins which determine the germ's resistance mechanisms. Bacteria and fungi can carry genes for many types of resistance. When already hard to treat germs have the right combination of resistance mechanisms, it can make all antibiotics or antifungals ineffective, resulting in untreatable infections. So how can we as healthcare personnel on the front lines help eliminate the spread of these harmful organisms? First, let's review where these germs live. Remember, germs can live in the body and in the environment. In the human body, we have skin, the gastrointestinal system or gut, the respiratory system, and blood. The skin or a wound can be colonized with a resistant strain of Pseudomonas, for example. Can you think of other resistant organisms that can live on the skin? We talked about Candida auris, MRSA, and others. In the healthcare environment, we have water and wet surfaces, dry surfaces, dirt and dust, and devices. These organisms can live and thrive in any of these reservoirs. Although EBP focuses on high-contact resident care activities, it is important to know the germs can remain in the environment for long periods of time as well. Devices can harvest bacteria and facilitate spread from resident to resident, making it important to utilize the extra layer of protection, EBP, to prevent transmission from an environmental reservoir. Gown and glove use by EVS or other environmental service professionals or others responsible for cleaning and disinfecting at the point of care should be based on facility policy and for anticipated exposures to body fluid, chemical, or contaminated surfaces. It is important to remember gowns and gloves should be worn by EVS personnel when cleaning and disinfecting the rooms of residents on contact precautions. So now we've talked about where these germs live. How do these germs spread? And here are the 4 main pathways that germs spread and cause infection. In most cases, there are 4 main pathways for germs to be spread from reservoirs in healthcare. The first is through touch. That usually involves the skin, especially the hands, but it also happens with devices which touch different people and surfaces. Another pathway for germs is through breathing in. A third is through splashes or sprays of blood, body fluid, or water from a sink or other source. Germs in those splashes and sprays can get into a person's eyes, nose, or mouth, or into a cut or a break in the skin and cause infection. The last common pathway for germ spread in healthcare is through clinical care tasks that bypass or break down the body's natural defenses, like when a patient's skin has to be broken to insert an IV, that creates a pathway for germs to enter the patient's body. So now we're going to talk about some infection control actions that we can take to help reduce the spread of these MDROs in healthcare facilities. So first I want to talk about standard precautions. This may be a review, but it's always good to review. The standard precautions is a group of infection prevention practices that apply to the care of all residents, regardless of suspected or confirmed infection or colonization status. They are based on the principle that all blood, body fluids, secretions, and excretions, except sweat, may contain transmissible infectious agents. Proper selection and use of PPE, personal protective equipment, such as gowns and gloves, is one component of standard precautions, along with hand hygiene, safe injection practices, respiratory hygiene and cough etiquette, environmental cleaning and disinfection, and reprocessing of reusable medical equipment. Use of PPE is based on staff interaction with residents and the potential for exposure to blood, body fluids, or pathogens. Example, gloves are worn when contact with blood, body fluids, mucous membranes, non-intact skin, or potentially contaminated surfaces or equipment are anticipated. More detail about standard precautions is available as part of the core infection prevention and control practices for safe healthcare delivery in all settings. And Project Firstline does have specialized trainings on standard precautions that you can access as well. So in review, standard precautions applies to all residents. PPE is used for these situations. Any potential exposure to blood, body fluids, mucous membranes, non-intact skin, potentially contaminated environmental surfaces or equipment, depending on anticipated exposure, gloves, gown, or face mask or eye protection should be used, and there are no room restrictions. So our next infection control action I want to talk about is antimicrobial stewardship. Antibiotic use is a major risk factor for developing drug-resistant infections. More than 2.8 million antimicrobial resistant infections occur in the United States each year, and more than 35,000 people die as a result. Ensuring appropriate use of antibiotics is one of CDC's core strategies to combat the threat of antimicrobial resistance. Antibiotic stewardship is also important to ensure equitable access to high-quality health care and to optimize treatment of infections and patient safety. So why is this so important? As healthcare personnel, we must advocate for the best outcomes for our patients. Gaining knowledge about antimicrobial stewardship can empower us to encourage prescribers to make informed decisions about treatment options, especially for those who are most at risk for multidrug-resistant organisms. Improving the use of antibiotics in healthcare to protect patients and reduce the threat of antibiotic resistance is a national priority. Antibiotic stewardship refers to a set of commitments and actions designed to optimize the treatment of infections while reducing the adverse events associated with antibiotic use. The Center for Disease Control and Prevention recommends that all nursing homes take steps to improve antibiotic prescribing practices and reduce inappropriate use. Antibiotics are the most frequently prescribed medication in nursing homes, with up to 70% of residents in a nursing home receiving one or more courses of systemic antibiotics when followed over a year. Nursing homes are encouraged to work in a stepwise fashion, implementing one or two core element activities to start and gradually adding new strategies from each element over time. Any action taken to improve antibiotic use is expected to reduce adverse events, prevent emergence of resistance, and lead to better outcomes for residents in this setting. And now I'm going to show a brief video on enhanced barrier precautions, what we've all been waiting for. And that will go over enhanced barrier precautions, and then we'll go into a little bit more depth on the subject.
As long-term care professionals, our jobs make a difference. It's not always easy. Each day can bring new challenges. But the effort we put in can be life-changing for someone's parent, grandparent, sibling, or partner. Threats to our residents' health are changing, and we must adapt to protect them. Multidrug-resistant organisms, or MDROs, are a known threat to nursing home residents. MDROs are resistant to multiple antibiotics or antifungals, meaning the drug has lost its effectiveness and cannot stop the germ. One way to protect our residents from getting hard-to-treat infections is to stop the spread of MDROs in our nursing home facilities. Unfortunately, many of these germs are often found in our facilities, on surfaces, and even on the hands of residents and staff. Residents can even have the resistant germ in or on their body without showing any signs or symptoms of active infection. This is a condition known as colonization. In fact, more than 50% of our nursing home residents may already be colonized with an MDRO. And because MDROs can spread undetected, we could unintentionally spread these germs when we provide high-contact resident care. This puts our residents at risk for colonization or a serious infection. Thankfully, enhanced barrier precautions are a way we can help reduce this risk. Enhanced barrier precautions, or EBP, are among many infection prevention and control practices that we should use when interacting with residents who are at higher risk of infection. We should use EBP for residents who have wounds, indwelling medical devices, such as central venous lines and urinary catheters, or those who have been colonized by or infected with an MDRO. However, if residents need to be on contact precautions, use those instead of EBP. So, how do we use enhanced barrier precautions? Much of the care that we provide for residents is close contact and hands-on, the type of care that is likely to spread MDROs. We should use EBP during the following resident care activities: dressing, bathing, transferring, changing linens, assisting with toileting, accessing indwelling medical devices, and providing wound care. So, before we enter a resident's room marked with an EBP sign, or before we engage in high-contact resident care activities, we need to gather all needed supplies and materials, clean our hands, and correctly put on a gown and gloves. Once we have completed our care, we need to safely remove and throw away our gown and gloves in the room, and clean our hands again before moving on to provide care for another resident. When we use these precautions for every resident who is at higher risk, we can help reduce or even stop the spread of MDROs. Enhanced barrier precautions may be new to many nursing home staff and will require each of us to use the mindset that, as soon as we encounter a resident with a wound, indwelling medical device, or MDRO, EBP should begin. By following this guidance, along with other important infection prevention and control practices, we can reduce the need for isolation, providing our residents with a better quality of life. This is a step in the right direction, balancing safety and quality of life while decreasing the spread of MDROs. Thank you for taking this step with us.
All right. The video did a great job of explaining EBP. Now we're going to go into some detail on enhanced barrier precaution, and I'll pose these 6 questions that I like to think about when I talk about EBP. I'm going to go over each of these questions in detail and talk about the who, what, where, when, how, and why of implementation. And I'd like you to think about and encourage an individualized approach when implementing enhanced barrier precautions in your facilities. Think about how you can safely and effectively implement EBP to keep your staff and residents safe. Knowing the answer to the questions above will guide you in your approach to implementing this infection control action for vulnerable residents in long-term care facilities. We know that during a global pandemic and nationwide shutdown, we saw residents become socially isolated, which has proven to be very detrimental to overall health. EBP is a way that we can protect ourselves, we can protect our residents, and allow them to maintain their socialization within the facility in a dignified manner, lifting some of the stigma associated with infectious diseases and ongoing chronic diseases these residents are faced with in these settings. So what are enhanced barrier precautions? As the video spoke about, enhanced barrier precautions, or EBP, involve gown and glove use during high contact resident care activities for residents known to be colonized or infected with an MDRO, as well as those at increased risk of MDRO acquisition, including residents with wounds or indwelling medical devices. And where are we going to be implementing EBP? In skilled nursing long-term care facilities. MDROs, as we know, have a significant impact in nursing homes, and many residents are unknowingly colonized with an MDRO, especially residents with risk factors like indwelling medical devices or wounds. Residents who have had an MDRO can develop serious infections, remain colonized for long periods of time, and spread MDROs to others. Healthcare professionals can spread MDROs as well through contaminated hands and clothing. At this time, CDC has not recommended implementation of EBP in other healthcare settings. However, the evaluation for broader application of EBP to other healthcare settings is ongoing. So again, we'll talk about the why. Why are we implementing EBP in long-term care facilities? So implementation of contact precautions, as described in the CDC's Guideline for Isolation Precautions, is perceived to create challenges for nursing homes trying to balance the use of PPE and room restrictions to prevent MDRO transmission with residents' quality of life. Thus, many nursing homes only implement contact precaution when residents are infected with an MDRO and on treatment. Focusing only on residents with active infection fails to address the continued risk of transmission from residents with MDRO colonization, who, by definition, have no symptoms of illness. MDRO colonization may persist for long periods of time, sometimes months, which contributes to the silent spread of MDROs. With the need for an effective response to the detection of serious antibiotic resistance threats, there is growing evidence that the traditional implementation of contact precaution in nursing homes is not implementable for most residents for prevention of MDRO transmission. During a study published in the Journal of the American Medical Directors Association in 2019, nursing home residents were tested to see if they were colonized with an MDRO. The second column highlighted in red shows the percentage of residents who were colonized with an MDRO. In shifting the focus from actual infections to residents who may be colonized and taking into consideration the social and emotional burden of contact precautions, which may be in place for long periods of time, recent studies have indicated the use of EBP can effectively reduce the spread of MDROs while reducing resident isolation brought on by contact precautions. So why was adding another infection control action necessary? This study, along with containment strategies for outbreaks, have shown residents in nursing homes are at increased risk of becoming colonized and developing infection with MDROs. Nursing homes have been the setting for MDRO outbreaks, and when these MDROs result in resident infections, limited treatment options are available. So in 2019, CDC introduced a new approach to the use of PPE called Enhanced Barrier Precautions. This new approach recommended gowns and glove use for certain residents during specific high-contact resident care activities associated with MDRO transmission. CDC interim guidance recommends EBP as a strategy in nursing homes to interrupt the spread of novel or targeted MDROs, which we mentioned earlier. As described in the Healthcare Infection Control Practices Advisory Committee, or HICPAC, white paper, consideration for the use of enhanced barrier precautions in skilled nursing facilities, dated June of 2021, more than 50% of nursing home residents may be colonized with an MDRO. This report noted that the use of contact precautions to prevent MDRO transmission involves restricting residents to their rooms, which may negatively impact a resident's quality of life and psychosocial well-being. As a result, many nursing homes only implemented contact precautions when residents were infected with an MDRO. Based on available evidence and expert opinions, this white paper aimed to provide a consideration for broader use of EBP beyond targeted MDROs, including germs that affect every nursing home in the United States, such as Staph aureus, both methicillin sensitive and resistant. In general, gown and glove would not be required for resident care activities other than high-contact activities, unless otherwise necessary for adherence to standard precautions. Residents are not restricted to their rooms or limited from participation in group activities. Because EBP do not impose the same activity and room placement restrictions as contact precautions, they're intended to be in place for the duration of a resident's stay in the facility or until resolution of the wound or discontinuation of the indwelling medical device that placed them at higher risk. So when contact precautions do not apply, EBP are indicated for residents with any of the following. Resident is known to be infected or colonized with a novel or targeted MDRO that we spoke about earlier, or resident has a wound, indwelling medical device, and during high-contact resident care activities. When implementing contact precautions or enhanced barrier precautions, it is critical to ensure that staff have awareness of the facility's expectations about hand hygiene and gown and glove use, initial and refresher trainings, and access to appropriate supplies. To accomplish this, post clear signage on the door or wall outside the resident's room indicating the type of precautions and required PPE. For enhanced barrier precautions, signage should also clearly indicate the high-contact resident care activities that require the use of gown and gloves. Make PPE, including gowns and gloves, available immediately outside of the resident room. Ensure access to alcohol-based hand rub in every resident room, ideally both inside and outside of the room, and position a trash can inside the resident's room and near the exit for discarding PPE after removal, prior to exit of the room or before providing care for another resident in the same room. Incorporate periodic monitoring and assessment of adherence to determine the need for additional training and education. and provide education to residents and visitors. So let's talk about contact precautions versus EBP. Contact precautions are one type of transmission-based precautions that are used when pathogen transmission is not completely interrupted by standard precautions alone. Contact precautions are intended to prevent transmission of infectious agents like MDROs that are spread by direct or indirect contact with the resident or resident's environment. Contact precautions require the use of gown and gloves on every entry into a resident's room. The resident is given dedicated equipment if available, and is placed into a private room if available. When private rooms are not available, some residents may be cohorted or grouped together. Residents on contact precautions should be restricted to their rooms except for medically necessary care and restricted from participation in group activities. Because contact precautions require room restrictions, they are generally intended to be time-limited, and when implemented, should include a plan for discontinuation or de-escalation. And enhanced barrier precautions expand the use of PPE and refer to the use of gown and gloves during high-contact resident care activities that provide opportunities for transfer of MDROs to staff hands and clothing. MDROs may be indirectly transferred from resident to resident during these high-contact care activities. Nursing home residents with wounds and indwelling medical devices are at especially high risk of both acquisition and colonization with MDROs. The use of gown and gloves for high-contact resident care activities is indicated when contact precautions do not otherwise apply. For nursing home residents with wounds or indwelling medical devices, regardless of MDRO colonization, as well as for residents with MDRO infection or colonization. And here I just wanted to take a closer look at the similarities and differences between contact precautions and enhanced barrier precautions. PPE for enhanced barrier precautions is only necessary when performing high contact care activities and may not need to be donned prior to entering the resident's room, in contrast to contact precautions when PPE is indicated before entering the room. For example, staff entering the resident's room to answer a call light, converse with a resident, or provide medications who do not engage in a high-contact resident care activity would likely not need to employ EBP while interacting with the resident. Residents are not restricted to their rooms or limited from participation in group activity. Because EBP do not impose the same activity and room placement restrictions as contact precautions, they're intended to be in place for the duration of the resident's stay in the facility or until resolution of the wound or discontinuation of the medical device that placed them at higher risk. So I have a little scenario I'd like to go over, and if you want to use the chat to share your answers here. Mr. A was admitted to your facility for short-term rehab after a two-week stay at a nearby acute care hospital. He has a surgical wound on his lower leg and requires dialysis 3 days a week via an external indwelling catheter. On admission, what precautions would Mr. A be placed on and why? So go ahead and share in the chat. What precautions would you place Mr. A on admission? Good, we get some EBP. EBP, yep, that sounds appropriate. He has an indwelling medical device and a wound. Good. Yep, indwelling catheter. Great. 4 days into his stay, he develops purulent wound drainage, lethargy, and fevers. His wound culture grows CRPA, carbapenem-resistant Pseudomonas aeruginosa. Now, how do you proceed? Continue with EBP or change to contact precautions? Okay, so you're going to upgrade to contact precautions. Good, very good. Great. So how will you communicate this with other entities such as the dialysis facility, the resident, staff, and visitors? Signage, yep, great. COC, excellent, yep. There should be a place on the COC to indicate infection status. Great, very good. Communication book, yep, some facilities have a communication book with the dialysis facility. Perfect. Awesome, very good. So Mr. A is treated for his surgical wound infection and his wound drainage subsides and is contained. Should he continue to be maintained on contact precautions, or can he be transitioned back to EBP, and when? Sure, I can repeat. Mr. A is treated for a surgical wound infection and his wound drainage has subsided and is contained. Should he continue to be maintained on contact precautions, or can he be transitioned back to EBP, and when? EBP once antibiotic finishes and symptoms subside. Transition back to EBP when completed antibiotics. So that would have to be an interdisciplinary team decision on when to transfer back to EBP once he is no longer considered infectious. Great. Oh, thank you so much for participating. That was great. I appreciate it. All right, moving on. So as we know, we spoke about, residents in long-term care facilities are at risk for being colonized with MDROs. Colonization can occur before or after active infection with an organism. The germ can remain in or on the body and not make someone sick. Being colonized with an MDRO does not mean the person cannot spread the germ, leading to silent spread of infection. Thus, it's important to differentiate if a resident is colonized or actively sick with infection, which we just did in our scenario there. It may be helpful to implement a protocol to determine if signs and symptoms of infection are assessed and create a criteria for initiating contact precautions empirically if a resident on EBP develops increased wound drainage, loose stools, or other systemic changes as listed here on the slide, including how you will communicate the change from EBP to DBP to staff, residents, and others involved in the care of the resident. So as we mentioned, who are we implementing this for? Any resident living in a long-term care facility that meet any of the following criteria: have a history of MDRO, high risk, or have high risk of acquiring one, colonization of infection with a targeted MDRO such as CRE when contact precautions are not indicated, those with an indwelling medical device such as a PICC line, feeding tube, or urinary catheter, that's peripherally inserted central catheter, residents with a chronic open wound, pressure injury, surgical wound. So who in your facility meets the criteria, and how are you going to assess and document? Remember, your specific facility policy should indicate the criteria decided on based on an interdisciplinary team decision-making approach. After taking into consideration factors such as MDRO pressure, antibiotic use, and resident acuity, a documented facility-specific criteria should be outlined to limit any confusion as to which residents meet criteria for use of EBP. All right, and you guys did so great in the last scenario. I have one more for you. And using EBP, you'll be providing an additional level of protection with gowns and gloves as a barrier for potential pathways MDROs can enter the resident's body. You'll be protecting the most vulnerable from potential infection. So let's put this into practice. And again, please share your answers in the chat. In this scenario, your facility has not yet implemented EBP. So you're about to administer a nebulizer to your resident via open tracheostomy. The resident has a positive sputum culture that grew a pan-resistant Pseudomonas aeruginosa during their most recent hospital stay 1 month ago. They're in recovery and recently finished a course of IV antibiotics. The resident is considered colonized with P. aeruginosa. What type of PPE should you use while assisting with a nebulizer for a patient with an open tracheostomy? What infection control risks do you anticipate in this scenario? Go ahead and use the chat to share your feedback. So what type of PPE should you use while assisting with a nebulizer for a patient with an open tracheostomy? So glove, gown, mask, gown, gloves, mask, EBP, gloves, gown, and mask. Good. So using your clinical judgment and decided to use standard precautions, including the use of hand hygiene, use of gloves, a surgical mask, and eye protection during this activity. Good. Mask, goggles, gown, and mask. Great. You don all appropriate PPE and enter the room. You approach the resident to perform a respiratory assessment and the resident coughs. You don't realize your clothing has become contaminated through splashes and sprays of sputum from the cough. While you're in the room, the resident requests suctioning and assistance with repositioning in bed. You proceed to assist with these activities. Would you consider any of these care activities to be high contact care activities? Go ahead and share in the chat. Yes. Yes. Very good. Yes. Excellent. So you finish caring for this resident, doff all PPE and perform hand hygiene. You then move to another room to assist a different resident with urinary catheter care. You decide to use standard precautions including hand hygiene and glove use. You lean over the bed and your clothing touches the catheter tubing and linens, potentially contaminating the catheter and likely entering the body through the pathway urinary tract. How could have transmission been interrupted in this case? What additional infection control actions could have been used to stop the spread of infection? Right, wear a gown. EBP, yep, EBP. So if EBP was in place, you would have been wearing a gown, and that could lead to stop the transmission in this scenario. Very good. Change gown, EBP. All right, very good. All right, and we talked about the high contact care activities that require gown and glove use, and the CDC has formulated this list based on research. So in addition to standard precautions, use EBP during these high contact resident care activities: bathing, showering, transferring, dressing, changing briefs or assisting with toileting, wound care, device care, providing hygiene, and changing linens. And remember, this list is used for reference, and EBP applies to all of these activities. There may be additional activities and needs for each individual resident. Being transparent with all care providers on what is expected for each resident while implementing EBP can lead to successful outcomes. Also, it's important to document rationales using evidence-based and interdisciplinary protocols behind all decisions regarding EBP as to eliminate barriers for personnel during implementation at the bedside. And this list, as I said, is not fully exhaustive. Facilities could consider adding other activities specific to the residents, and remember to document specific for the individual. So how are we going to do this? How are we going to begin? Developing an action plan is vital to success. So I'll ask, what goals do you have for implementation of EBP? Will you be implementing facility-wide to start, or just on a specific unit with high-risk vulnerable residents, then expand to other units? Which residents will you include? How will you document this? Does your facility have a designated person for confirming which residents meet EBP criteria? Who will be responsible for ordering and restocking PPE? How will you communicate to residents, staff, and others involved in their care? What is expected once implemented? How will you address any barriers to implementation? How and when will audits occur to monitor for any gaps in practice? And when breaches occur, what education tools will you be using? And what is your plan for providing feedback? A systematic approach to implementation involving leadership with a focus on key areas such as resident assessment, including infection status and presence of wounds or devices, auditing and feedback, interactive education and tools to foster adherence, and communication with all involved in care as to what is expected are some key strategies to successful implementation. So the CDC has developed this new pre-implementation tool, and it's designed to be used prior to implementation of EBP in your facility, either on a unit, wing, or the entire facility. And it's used as a guide for developing a successful plan for implementation of EBP during high-contact resident care activities. It is intended for use in the skilled nursing facilities and nursing homes only, and Abby will be sharing a link to the tool in the chat, so you'll have that readily accessible. And also they've developed Enhanced Barrier Precaution Implementation Observation Tool, and this should be used only after you've established the use of EBP in your facility and can be customized to meet the needs of the skilled nursing facility, nursing home. This tool is designed to support the conducting of observations of healthcare personnel using EBP during high-contact resident care activities as part of auditing and feedback, and responses should refer to current practices. This observation tool is helpful in auditing staff after implementation, but can also be used to guide leadership in developing useful tools to assess residents for use of EBP safely and effectively in the facility. And this tool is effective. It's an infographic with the EBP signage and some details regarding why we're implementing EBP. And you can post this in your facility for staff, residents, and visitors. Just for a quick reference, if they have any questions, they can refer to that poster. And we also have, CDC has also developed this Enhanced Barrier Precaution Pocket Guide, and Abby will be sharing the link for that in the chat as well. This could be printed and folded, tri-fold, and put in your pocket, and you can refer to it at the bed, before entering the room, just to make sure you're hitting all the key areas before implementing EBP. That's a good little tool to have on hand as well. All right, very good. So we've covered a lot today, but here are some key takeaways. MDROs are a major health threat to residents in long-term care facilities. Implementation of infection control actions, such as standard precautions and EBP, are recommended by the CDC as an effective strategy to reduce the spread of MDROs. And using an individualized approach to implementation can be useful in assuring successful outcomes. All right, very good. Here are resources and future training sessions. To register for our live webinars, please visit our website, and you can connect with us on any of these social media outlets. In our upcoming training sessions, I will be presenting this session again on this Thursday, April 11th from 10 to 11 a.m. And please feel free to share that widely with your colleagues, or feel free to come again if you'd like. And then we have a tentative date, April 29th from 12 to 1 for measles in a healthcare setting and infection prevention and control refresher, presented by my colleague Lisa Ledoux. And here are references which will be shared with you in our post-training resources. And just a quick reminder, a few requirements to receive your certificate of training or your continuing education credit. Please be sure to fill out your post-session survey and quiz, and your certificate will be emailed out once you complete all the required activities on April 18th. All right, and we just have a quick end-of-session feedback poll If you wouldn't mind just filling that out for us, and then we'll go right into our Q&A. We just have a few minutes left. I just want to be mindful of everyone's time, especially if you want to view that solar eclipse today. We'll get you going right at 1 o'clock, but we do want to address any questions if you do have questions. And I do see a few in the Q&A box there, so we'll take a look at those. Thanks so much. I'm really excited to present this topic to you, and I will be back again on Thursday to do the same. Thank you so much, everyone, and enjoy your afternoon, and be safe if you're viewing that eclipse today. And we hope to see you again in the future. And again, we will answer all of your questions, and have a great afternoon. And thank you so much again for coming to our webinar today.